Care of the woman and her family during labor and birth is a rewarding yet demanding specialty within nursing. New nurses and nursing students often approach care of the laboring woman with apprehension. They must face several common issues when caring for families during birth. Working with people in pain is difficult, and most nurses feel compelled to relieve pain promptly, yet pain is expected in labor and cannot be eliminated. Mothers who want some form of analgesia during labor must experience some pain before the analgesia is given for birth. Helping the woman manage the pain of birth is a critical part of nursing care. The nurse who has never given birth may feel inadequate to care for the laboring woman. However, the same nurse rarely believes that his or her previous experience of a fracture, for example, is necessary to provide care for a patient with a fracture. Birth follows its own timetable, even with efforts to manage it. Some nurses find the uncertain nature of an intrapartum area troubling, whereas others find it exciting. The intimate nature of intrapartum care and its sexual overtones make some nurses feel uncomfortable. They may feel that they are intruding on private time. During the last trimester, the woman needs to know when she should go to the hospital or birth center. Factors she should consider includes number and duration of previous labors, distance from the hospital, available transportation, and child care needs. In their prenatal care, nurses teach women to distinguish between false and true labor. Nurses teach guidelines for going to the birth center and reinforce those given by the physician or nurse midwife. What are the nurse's responsibilities during admission? The two nursing priorities when a woman arrives at the birth center are to, first, establish a therapeutic relationship, and two, assess the condition of the mother and fetus. The nurse must quickly establish a therapeutic relationship with the woman and her significant other. The woman's first impression influences her perception of the quality of her entire birth experience. Regardless of their number of children, women and their partners have expectations about their birth experience. The partners may have studied their options extensively and planned a birth that best fits their needs. From the first encounter, the nurse should convey confidence and optimism in the woman's ability to give birth and the ability of her significant other to support her. You must also assign a primary nurse. Having one nurse give care during all of the labor is ideal, but often unrealistic. However, changes in caregivers should be as limited as possible. Touch can communicate acceptance and reassurance and provide physical and emotional comfort to many laboring women. We must also respect cultural values. Cultural beliefs and practices give structure, meaning, and richness to the birth experience. Our first priority is to have a focused assessment. A focused assessment is performed before the broader database assessment in the intrapartum unit, opposite of the usual order. Assessment priorities are to determine the condition of the mother and fetus and whether birth is imminent. First, we got to worry about fetal heart rate. For assessment of a term fetus using intermittent auscultation, we are looking for a range between 110 and 160, regular rhythm, presence of A cells, and absence of D cells. Maternal vital signs are assessed to identify signs of hypertension and infection. And grunting sounds, bearing down, sitting on one's buttocks and saying the baby is coming suggest intimate births. The nurse abbreviates the initial assessment and collects other information after birth. While the nurse cares for the mother, minimal information can be gathered quickly if birth is imminent. Database assessment. In addition to performing the focused assessment, the nurse should assess the mother, fetus, and available maternal support persons. The basic information. Intrapartum admission forms guide the nurse to obtain the required information. What we're looking for essential information is the woman's reason for coming to the hospital or birth center. Was it for rupture of membranes? Was it for contractions or vaginal bleeding? Etc. Prenatal care. When it began, her most recent visit, and the name of her physician or nurse midwife. When is her estimated date of delivery? Number of pregnancies, births, spontaneous pregnancy losses, and elective abortions. That would be our GTPAL that we learned in antepartum. And any allergies she should have, particularly such as latex or medications. When did she eat last? Is she on any medications? Her subjective evaluation of her labor. Any illicit substance use, including tobacco and alcohol? And is there any potential domestic violence? In our fetal assessment, we want to know the presentation and position, and this is obtained through a vag exam if it's not contraindicated, along with a Leopold's maneuver. The fetal heart rate is assessed by intermittent auscultation and electronic monitoring. And if the water is broken, the nurse documents the color, the odor, and the time of rupture if the membranes ruptured before admission. We also need to know her labor status. The woman's labor status is determined by assessing her contraction pattern, performing a vag exam if there are no contractions, and determining if her membranes have ruptured. Contractions are assessed by palpation. Remember, unless we have an internal monitor, strength of contractions and the rest between contractions can only be assessed by palpation. We also need to know if there is any active vaginal bleeding. On the physical exam, a brief physical exam evaluates the woman's overall health. And we would also look for any type of edema and abdominal scars and the height of the fundus. After assessing, the nurse notifies the woman's birth attendant to report the woman's status and obtain orders. Important point, remember the fetal assessment is a baseline of 20 minutes. You must have at least 20 minutes of baseline fetal heart rate strip for a fetal assessment. What would be good before notifying the birth attendant is immediately when a woman walks onto the unit, you start her on a fetal heart rate monitor, and then you can ask her questions and do the vag exam while that strip's running. That way you have all your needed information before calling the healthcare provider for your fetal evaluation and assessment and your mother assessment. So after doing that assessment, you would notify the woman's birth healthcare provider to report the woman's status and obtain orders. So again, from our assessment, we would let the healthcare provider know the GTPAL, estimated due date, fundal height if it conflicts, any type of contraction pattern, any results of our vag exam, fetal presentation, also if her membrane status, the fetal heart rate pattern, maternal vital signs, and any abnormalities that we are aware of. Consent forms are signed if they weren't done on pre-registration. There may be additional consent forms if additional procedures are done, such as circumcision of the baby after birth. We would do laboratory tests. We always do a baseline CBC and type and cross, and a urine to assess for protein and glucose. We would start IV. IV is always 18 gauge or larger. This is in case we have to provide blood. We need to have at least an 18 or larger catheter to accommodate that. A saline lock may be used instead of running continuous fluids. This allows her to walk during early labor. Perineal preparation. The perineal preparation is not very common at all anymore. That is where they may clip the hair near the skin, and this is done when it actually gets to the point of delivery, and because of the risk of infection, it's really not done that commonly anymore. Enemas are not routinely done anymore either. The only time they may consider doing it is if they felt there was so much stool that it was interfering with fetal descent. Assessment after admission. Okay, once we decide that she will be admitted and she's not in triage, first thing is a fetal assessment. We would continue to monitor the fetal heart rate. Remember, baseline changes is 10 minutes, so if you're saying a baby went from regular to tachycardia, it would have to be tachycardic at least 10 minutes. That was reviewed in our fetal assessment in our antepartum module. We would also assess amniotic fluid. If it should rupture, we would need to know, again, color. Also, is the cord compressed? Has she felt fetal movement recently? If the provider artificially ruptures the membranes to facilitate labor or to have access to put in internal monitoring, we have to monitor the fetal heart rate at least 1 minute after the membrane's ruptured to make sure we don't have a prolapse cord. Remember, amniotic fluid should be clear. It might have some vernix in it. Cloudy yellow and foul-smelling amniotic fluid suggests infection. And if it's green, then we know that's meconium. Meconium is what's considered the first stool of the fetus. And sometimes the fetus, if they breathe, that might go into respiratory distress after birth. Maternal assessments are worried about vital signs, contraction pattern. How is her labor progressing as far as dilation, contraction, and station, which is related to fetal descent. Intake and output. How is she responding to labor? And how is the support person doing? Labor is stressful for the woman support person. The support person may become anxious, fearful, or tired. And nurses should encourage the presence of the partner during the labor process. One of the big things that happen is early versus false labor. So how can we apply the nursing process to false or early labor? Our assessment, after observation, the nurse may realize that the woman is not in true active labor. Of course, our biggest measure is progressive dilation and effacement. And in our analysis, a woman may be frustrated because she cannot tell whether labor is real. She may be frustrated with continuing to be pregnant. And in our plan, we're hoping that she is able to describe the reasons for returning to the birth center for evaluation. We will reassure her that when she's ready, she will go into labor, provide teaching about when she should be back, and evaluate her understanding of these directions for false labor. If it is true labor, we're going to confirm it by progressive dilation and effacement. Part of our assessment will be fetal heart rate, assessment of amniotic fluid and time, maternal vital signs, and our contractions. Some of the things we would look at in our assessment that would be conditions associated with fetal compromise. This is critical to remember. Fetal heart rate outside the normal range of 110 to 160, meconium fluid, or cloudy yellowish foul-smelling amniotic fluid. Excessive frequency or duration of contractions, because that reduces placental blood flow. Remember, no more than 90 seconds. Rest should be a minimum of 30. Does she have maternal hypertension and a fever? Hypotension is also something we would be concerned about. It can affect fetal compromise by that it will not, if she's hypotensive below 90/50, she does not have enough pressure to nourish the placenta. And of course, our immediate interventions for low blood pressure or high blood pressure: turn to left side, provide oxygen, and provide fluids. What is our, suppose we do have someone coming in, or let's at least finish this planning. Interventions promote placental function, which I just went over. We're going to continue to observe for conditions associated with fetal compromise. And next, what to do if we have an emergency delivery in that situation, true labor, the provider did not get to the birth center yet. Your priority as a nurse is to prevent injury to the mother and infant and maintain the infant's airway and temperature after birth. We have to locate the emergency delivery tray. It's called the precipitous tray. We remain with her, put on gloves, and assist with the birth. Stay calm, and after birth, observe the infant's color, respiratory for distress. Remember being careful with suctioning. Just wipe the mouth out. You don't want a deep suction because you can vagal that baby's heart rate down. We dry the infant for maintaining its body temperature and place skin to skin with the mother, and encourage breastfeeding. Fetal oxygenation. In our assessment, we will look at the fetal strip. We can assess, again, we're looking for late D cells or possible variable D cells. Provide teaching in our plan. We're hoping all the babies or fetuses ranges are with normal. That would be the presence of A cells, heart rate within normal limits, the absence of D cells. We can promote maternal positioning, again to the left. And then evaluate. Discomfort, the pain. We can provide cleanliness, mouth care, make sure her bladder doesn't stay full, provide positioning, ice chips, and provide teaching to her about the different stages of labor and what to expect during active and transition and pushing. We also can provide medication, and don't forget about the birth partner. Preventing injury. Nursing assessments of the mother and fetus continue as the woman nears birth. During the second stage, observe her perineum to determine when to make final birth preparations. There's always a risk for injury related to altered sensations. And your plan is to prevent and minimize injuries during birth. We're going to position her for birth, put her in the stirrups, observe the perineum, And then evaluate as far as her goal that the baby, the fetus, and newborn are born without any injury to mother or fetus. So during the late intrapartum period, what is nursing care? During birth, we're going to aid with the delivery of the placenta. That would include massaging after delivery, preparing and prepping the perineal area, cleansing the infant's airway, and if needed, cutting the cord. The nurses are also responsible for preparation of the delivery table with sterile gowns, gloves, drapes, and solutions. After birth, the nurse is responsible for care of the infant, maintaining cardiopulmonary function. That means taking the AVCAR scores at 1 and 5 minutes. Make sure the baby maintains its body temperature. That would be placing the infant skin to skin, warming it with warm towels, and also identifying it. Bands are applied before that baby leaves that room to mom and baby, and taking footprints. We are also responsible for promoting early family attachment, especially at breastfeeding. Make sure that the mother puts it to the breast. In care of the mother, we observe for hemorrhage, vital signs every 15 minutes during the first hour, assess fundal height, assess for a full bladder because that can impede the fundus from constricting down, assess the lochia and the labial perineal area for any type of hematoma or lacerations. We also want to provide comfort, such as ice packs to the perineum after vaginal birth, provide pain medication, and warmth because she goes through the stages of having chills. Now, if you need to cut, if you do an emergency delivery, and there's some concerns such as with nuchal cord, because you may have to cut it. So we're going to take a look at that. If you have to do emergency delivery, you assess for the cord when you deliver a baby, you pull it over the neck. But if it's tight, clamp the cord twice in an accessible area, the hemostats. Make sure you don't clamp or cut the baby. Remember, once clamped, the baby will no longer receive oxygen from the placenta, so complete delivery should be prompt. Remember, this is done if the cord is very tight around the neck and you cannot pull it over the baby's head. Next, we're going to go over, if you explain to someone in a situation, on what to do with an emergency delivery.
So what is Athena Health? We provide integrated practice management, electronic health.
How to deliver a baby in an emergency. You can see the baby's head, but there's no doctor in sight. First, calm down. Then follow these instructions. You will need sheets, towels, or clean clothing, hand sanitizer or soap and water, shoelaces or string, and clean scissors. When delivering a baby, do not try to pull out either the child or the umbilical cord. Step 1. Put down some sheets, towels, clothing, or even an unread newspaper. Anything you can find that's clean. Step 2. If you have assistance and she's comfortable with it, help the mom-to-be stand with her knees slightly bent. That way, gravity will be on your side. Otherwise, have her lie on her back, then prop up her back with something soft. Step 3. Scrub your hands as well as your arms up to your elbows with hand sanitizer or soap and warm water. Step 4. Remind the mom-to-be to take deep breaths and to push. Step 5. Once the baby's head emerges, tell the mother to stop pushing. Step 6. Gently cradle the baby's head, then prepare to catch. After the shoulders slip out one at a time, the rest of the body will quickly follow. Step 7. Leave the cord cutting to a medical professional. If the cord is wrapped tightly around the baby's neck, preventing the infant from breathing, tie shoelaces, string, or some dental floss around the cord in 2 places, about 4 and 8 inches from the baby's navel, to cut off the blood flow. Knot them tightly, then cut the cord in the middle with clean scissors. Once it's cut, gently unwrap the cord from the neck. Make sure you leave enough space between the ties and your cut so that the knots remain secure. Otherwise, the baby could bleed to death. Step 8. Clear the baby's air passages by gently stroking downward on its nose and mouth. If the baby doesn't seem to be breathing, gently slap the bottom of its feet. If that doesn't work, blow a few gentle breaths into the baby's mouth. Step 9. Wrap the baby in something clean and soft to keep it warm. Step 10. Encourage the new mom to breastfeed immediately. This will help her body expel the placenta and stop her bleeding. Let the placenta emerge on its own. Don't try to pull it out. Save it for the doctor who will want to examine it. Step 11. Now get mom and baby to the hospital or call 911. Did you know? According to the Centers for Disease Control, 30% of babies born in America are delivered by cesarean section.
Something else you may want to do is turning up the heat when you deliver an infant. I know in labor and delivery we used to turn up the heat in the room when it was due to help the baby with body temperature regulation. So if you're explaining to someone how to do an emergency delivery, such in a car, you would tell them turn up the heat in the car. And that's it for this lecture.